And a very good evening to you. I am Lisa Lord, and on this one-on-one, my special guest is consultant obstetrician, gynecologist, and gyne-oncologist, Dr. Vikash Chatrani. Dr. Chatrani, thank you so much for joining us.
Thank you, Lisa, for having me
this
evening.
Welcome. Now, your field of specialization covers a myriad of issues. We're going to try to cover as many as possible. So let's start with gynecology. Sure. One of the conditions affecting a lot of females is endometriosis. And I say females and not women because a lot of very young girls are also suffering from endometriosis. So I want you to explain endometriosis.
So, to understand endometriosis, you have to understand what happens with the womb on a monthly basis. So your womb cries in your reproductive age when you don't get pregnant, and that's your menstrual effluent or your menstrual flow, the passage of the lining of the uterus every month to replenish it. When that lining is present outside the uterus, it can be on the ovary, on the cervix, on the uterine body on the outside, on the peritoneal coverings of the internal linings, that bleeds every month too as well. So if there's internal bleeding, you're going to get pain and discomfort from that bleeding, and that's really what manifests the pain that occurs with endometriosis.
How common is it?
It's not very uncommon. It's quite common. I would say at least 15 to 20% of our women experience endometriosis, and some of it is even undiagnosed. You only find it by chance. They just think that they're supposed to have a little pain with their periods. Some have it very severe. So sometimes just at surgery, we know we're doing surgery for other reasons, you identify and see endometriosis, and we call that the asymptomatic population. But then we've been seeing a lot of patients present recently with significant disease and pain and discomfort from it on a monthly basis.
That was going to be my next question. How do I differentiate period pain, normal period pain, what I consider to be normal period pain, versus me needing to go to the doctor and then perhaps having a medical condition?
Right. So a lot of people do experience discomfort with their periods. Just the passage of clots or bleeding is an unhappy time for them. And really and truly, if you can manage it with mild analgesics, mild painkillers like Panadol, we don't usually go investigating for endometriosis. But if you get specific symptoms like one-sided pain, it occurs every month, it's debilitating, where it stops you from going to school or going to work, it has an impact that you can't even function, you're bedridden for that day, or you're having to take strong medication to help control that pain, then it warrants further investigation. Now, the gold standard for investigating something like endometriosis is something called a laparoscopy. And a laparoscopy is basically a big word to help describe just simply putting a camera through the belly button or navel and taking a look. Because from what I described, endometriosis doesn't occur in the cavity of the uterus, it actually occurs on the outside. So you kind of want to view the organs on the outside to see if you see any what we call burnt out lesions, any active lesions, any blood there to help make the diagnosis. But obviously to do laparoscopy, we have to anesthetize a patient and put them to sleep. So sometimes we actually institute medical management without even confirming the diagnosis. In other words, you suspect the diagnosis and you start treatment accordingly. And the treatment doesn't have to be hormones. You could start off with painkillers. Some people who have mild or moderate period pains, you give them painkillers or you give them something to control their bleeding and the symptoms become less. Simple things that can be used to help control their periods would be like the oral contraceptive pill. So it's kind of like a trial of treatment. You could start somebody on the pill, their symptoms improve, and you can then decipher that maybe they have endometriosis without having to undergo surgery and prove the diagnosis.
But 15 to 20% of the female population who have a period, that's a lot.
Right, but 15 to 20% don't have to be symptomatic.
Still significant.
Yeah, and similar with polycystic ovarian syndrome.
Let's talk about
that's another common one that has such a high incidence, and everybody doesn't experience all the discomfort from it. Now, polycystic ovarian syndrome is a misnomer in my thinking, because when you think about it, you think it's just something affecting your ovaries. But it does not just affect your ovaries. It's a metabolic syndrome. Metabolic syndrome means it infects the entire body. And yes, you may have to have polycystic ovaries on ultrasound to prove the diagnosis, but you can actually have the diagnosis without having polycystic ovaries on ultrasound. You only need 2 out of 3 things to prove the diagnosis of PCOS, or polycystic ovarian syndrome. You need to have either irregular periods or absent periods. evidence of excess androgens, which is a male hormone, and that could be hair growth.
Yeah.
Or ultrasound evidence of polycystic ovary. So if you just need 2 out of the 3 things to come up with a diagnosis, you don't even need to see your ovaries to prove that diagnosis. You may have a patient present with hirsutism or excessive hair growth with irregular periods, and you could make that diagnosis straight off without doing an ultrasound.
We spoke about endometriosis, PCOS, adenomyosis.
So adenomyosis, you've been giving us all the big words. So adenomyosis is basically when you have endometrium, that's the lining of the womb, that's what sheds every month. The endometrium is actually now present in the walls of the uterus. So when you are supposed to bleed every month and you pass your menstrual effluent, what's happening is that you're bleeding in the walls of the uterus. So it's like if you received a cuff with a knuckle in your muscle, you know how it becomes black and blue and tender and swollen, and the muscle is swollen? The same thing happens with the walls of the uterus. So your uterus over time enlarges and becomes bulky, and your periods then become heavier and more painful. And that's why the only treatment for endometriosis is either stopping your periods or removing the uterus to prove that diagnosis.
And in terms of the cases that you would see with that condition?
So endometriosis you usually see in women above 40s. They always complain of irregular, heavy bleeding or painful periods. And it's not in keeping with the history similar to endometriosis. And then when we do an ultrasound on them, you see that the uterus is enlarged, different to fibroids, you know, where you have these whorls of muscle, and you can then prove the diagnosis with something like an MRI or actually removing the uterus.
And you mentioned fibroids. Fibroids is something that a lot of women now are suffering with as well.
If you were alarmed by the comment that 15 to 20% of our patients suffer from endometriosis and polycystic ovarian syndrome, 80% of women in our population have fibroids.
Pause. 80%.
80%. Studies have shown that our women, 80% of women have fibroids, but only 25% of those 80% are symptomatic. That means a quarter. And uterine fibroids are very, very, very common. You know, most of the time patients don't know they have fibroids until they have an ultrasound. And they may have a small 2 centimeter or 1 centimeter fibroid, which is of no clinical significance, but the fact that they exist. And I have patients who have had scans for the first time. You do a scan on them and you see a small fibroid, and it's like a weight on their shoulders. I didn't know I have fibroids. And you have to explain to them, 80% of our women have fibroids. It's just common.
I didn't know that.
But only 25% are symptomatic. So having a small fibroid outside your uterus or inside the womb walls has no clinical sequelae. When I say no clinical sequelae, it wouldn't cause heavy periods, it wouldn't cause painful periods, it wouldn't cause infertility or problems conceiving. It has no issues whatsoever. But what we do is we monitor them. So on a yearly basis, we will monitor the growth of the fibroids. We obviously give them lifestyle factors to modify to prevent the growth of them, because most fibroids respond to estrogen. So excess estrogen in your body can actually cause the fibroids to grow. And you may ask me then, so what causes excess estrogen in your body? Well, it's not anything that you eat. Or well, maybe it is, because women who are overweight or obese have excess fat, and excess fat produces estrogen. So that's why when we look at things like polycystic ovarian syndrome, uterine fibroids, it's that we actually see uterine cancer also on the rise in Barbados. And that has to do with the obesity epidemic.
But I'm going to talk about gynecological cancers a little later, but getting back to fibroids, endometriosis, etc., these conditions do have some impact on fertility.
Yes. Yep. For polycystic ovarian syndrome, if you're not ovulating every month, you may have delayed fertility. So if you think about it, if you try every month to get pregnant and every month you don't ovulate, then your chances of getting pregnant decreases. So we don't call that infertility, we call that subfertility. And obviously if somebody is trying desperately to get pregnant every time they have a period, it's disheartening, to them that they have failed that month in achieving pregnancy. But once you manage these conditions, most of the times you can get your patients pregnant. So for polycystic ovarian syndrome, the underlying problem is really insulin resistance. And that's why I said it's kind of a misnomer, because the whole pathology behind, or the disorder behind polycystic ovarian syndrome is if you have excess insulin resistance, it means that your treatment approach should be a lifestyle treatment approach. So a change in behavior, increasing in exercise, modifying your diet, losing weight. And people ask, well, how can all those things change your ovaries? Well, it changes your whole metabolic profile. So that if you have less insulin in your body, because you're not having to produce higher levels to fight the resistance, then your hormonal imbalances kind of regulate themselves and you start to ovulate regularly on a monthly basis. Your periods start to come regular versus getting irregular periods, absent periods, or heavy periods. The whole clock is working in tune with the body. And when I talk about the clock, the reproductive clock.
Of course. And on that note, re-fertility, let's say 30 years ago, you did not hear as many women then as you do now complaining about not being able to get pregnant.
I wouldn't say they weren't complaining, is that 30 to 40 years ago, it was still taboo to consider fertility treatment. We have a very successful fertility center here in Barbados, and it's a mecca for patients coming from overseas to seek fertility options in the region, as well as even as far as North America. And now that we know there are treatment options out there, people are more open about their infertility or subfertility experience. And we don't call them infertility specialists, we call them fertility specialists because the goal is to get them pregnant. But it was common. You may find it a little bit more common now. I'll tell you why, because we've become a little bit more responsible in our sexual behavior. If you think of the pandemic in the 1980s, where you were dealing with the new virus, people then became a little bit more conscious about how they engaged in sexual practices. We found women advancing career-wise, and they may have been delaying, fertility for academic pursuits, for career opportunities, and they wait later in life. And then obviously waiting later, then they realize it was more of a challenge. So I think women are more empowered now. They focus not only on family, but they focus on developing careers and themselves and bettering society. Look, we have a president who's a female, a prime minister, female, often a deputy prime minister, female, multiple female ministers, female professionals. So, there are sacrifices that are made to be able to achieve those things. So I wouldn't say it's more common, but it's more spoken about because we have treatment options for them.
One of those treatment options in terms of family planning is the birth control pill. However, there's a belief amongst many women that being on the pill for an extensive period of time lessens your chances of becoming pregnant once you come off.
So to answer that question simply, no, that's not true. Being on the pill, it's a tablet you take every day. It influences your hormones to regulate them to some extent and stop you from ovulating. Once you come off that pill, you are able to return the next month to a normal ovulatory cycle. What happens though, people don't realize, if they take it for years, things change in their body. They may get older, right? Their eating habits and all change. So they attribute that they may be being comfortable in life, not exercising or whatnot, become overweight. So when they stop the pill and they realize that their periods are irregular or they're not ovulating every month or it's harder for them to conceive, it's easy to blame something that you were taking in the past, but it may just be your lifestyle that has contributed to that.
So nobody taking the pill, let's say for 20 years, it will have
We have no
impact.
evidence to support that, and the pill has been around for a long time.
Okay. But I am sure that you have heard that before.
I've heard people getting concerned about even taking some pills to as well cause them to put on weight. I mean, it's always, I'll give you an example, we just had a pandemic and most people in the country were vaccinated. And it's very easy for them to look back a couple months ago and say, well, this vaccine caused me to have this problem or to have that problem. When you look at the literature and you look at the evidence out there, some of them unrelated to that. But I don't want to go into vaccine because I know that's a topical issue, but I'm just giving you an example, We could blame 2 years ago the ash fall for a lot of things that are happening now. It's just something that happened at that time and it's easy to point a finger to, but it's not necessarily related. A causal effect, I would say.
Now, I want to turn our attention to obstetrics. Let's look at pregnancy, childbirth, and the postpartum period. What are you observing more in the pregnancies that you're seeing? I know that that is a broad question.
So I know you asked me before we must talk about miscarriage, and you said that there seems to be more miscarriages occurring now rather than in the past. And I don't want to say that's true. I'll explain why. 10% of pregnancies can end in a miscarriage in the first trimester. That's a statistic that is true, full stop. And you may know the old wives' tale, don't tell anybody you're pregnant until you've passed 12 weeks.
That's correct.
That's the reason for it. Your body has the intrinsic ability to detect when the fertilization process is abnormal, meaning that for you to get pregnant, sperm has to meet egg, you have to fertilize, and then that fertilized egg is what replicates. And if your body recognizes that there may be, for example, a genetic abnormality or a chromosomal abnormality, it can actually shut down the pregnancy and result in a miscarriage. So women who have miscarried in the first trimester, in the first 12 weeks, most of the times you don't even investigate it. You call that part of getting pregnant, that you 10% chance you may miscarry. If this is something that occurs on a regular basis in the same individual, meaning more than 3 times, then it warrants further investigation. But you say that you hear about it more often. I would be reversed in saying that people probably talk about it more often now because we have early diagnostic tools to detect pregnancy early, like an ultrasound or pregnancy tests. In the olden days, you had to miss a period once, twice, 3 times, then for you to suspect that you were pregnant. Now you can do home pregnancy tests where you can actually detect a positive pregnancy test before you even miss a period.
Yeah.
And then you can come into an obstetrician and get an ultrasound after 4 weeks and detect evidence of a pregnancy. So people are diagnosed earlier of being pregnant, and then obviously if 2 weeks later at 6 weeks they have a heavy period, then they know they had a miscarriage. Versus in the olden days where you didn't have those diagnostic tools, you didn't have pregnancy tests and ultrasounds, they would just say my period came 2 weeks late and it was heavy. So I don't want to say that we're having more. I mean, obviously when you have your population aging and people delaying fertility options until the 30s, then you may see the perpetuation for more genetic abnormalities, and then they may miscarry. Maybe that's a hypothesis that we could look into, but I wouldn't say it's any more than normal. Maybe it's just because of a taboo. People didn't want to talk about it.
I want to go back to something you just said, because I'm in my 30s. You just said waiting until they're in their 30s.
Yeah.
In your 30s, it's not advisable?
I didn't say that.
No.
But you,
I know you didn't.
interpret it as that.
That's why I'm
so
seeking
remember,
clarity.
people usually go through, or girls go through puberty around 13,
Yeah.
14. Most of the growth of women, they're fully functional reproductively women in terms of from 16 onwards. So when I say 30, that means 14 years after you've reached the ability to conceive is when you're looking to conceive. And if you think that, your chances start to decrease after 40, then you only really have 10 years between 30 and 40. And I know there's a terminology that the medical fraternity likes
That
to
we
use.
do not like.
That I don't like to use either.
You don't?
No, I don't use it at all.
Geriatric.
I don't like it at all. And that's after 35 years of age.
Yes.
A geriatric pregnancy.
Yes.
Horrible terminology. I mean, yes, we know that advanced maternal age has associated risks with it. The risk of developing hypertensive complications or high blood pressure in pregnancy, the risk of developing diabetes, the risk of genetic abnormalities. There are specific risks that we look out for. But I don't like that terminology either.
In your professional opinion, yes, you do not like the term geriatric pregnancy after 35. What is the ideal cutoff age for Dr. Chatrani? The age that he will say to a patient, I would not like you to go beyond this age and get pregnant.
Cutoff age? There's no cutoff age.
You just said that as a woman gets older, there's certain risks that come with age.
So just because there's a certain risk doesn't mean you must not try.
I know you know where I'm going.
I know, but I have to fight you on this.
No, you don't need to.
In the discussion.
Just answer me.
There is no cutoff.
There is
I've
no
delivered
cutoff.
a 47-year-old with advanced reproductive technique nowadays. You can bite your eggs in your 20s, in your 30s, and you could decide at 47 now is the time that you're ready to get pregnant and use those eggs and conceive.
Let me ask you another way, Dr. Chatrani, since you want to be difficult. I am 50 years old. I come to you as my obstetrician gynecologist and I say, I want to start a family. Are you going to tell me to go ahead?
I'm not going to stop you. If you can get eggs out of your ovaries at 50 years old, fine. If you cannot get eggs, you know what's going to happen? We're going to get you to the fertility center. You're going to choose donor eggs, and you're going to have your baby.
I'm also asking from the perspective of my womb having the capacity to carry a pregnancy full term at that age.
It does. Surprisingly, you may be alarmed by that.
No, I'm not.
So we have seen advancements in reproductive techniques in terms of things that we can do. There are things like surrogacy. There are things like donor eggs, donor sperm. There are things like banking eggs. We had a conversation earlier.
Yeah.
I had a patient who banked her eggs at an early age and then opted in her 40s then to withdraw from the bank and implement them and fertilize herself and get pregnant.
That's also if you can afford it.
I'm not saying it's
expensive.
inexpensive. It is expensive, but people don't even explore the cost. They automatically assume raising a child is very expensive.
Yes, it is.
You know, having first to go through the hospital, have a baby, one, then buying baby supplies, two, doctors, education, clothing, nourishment, all those things, college. Having children is expensive, but it's the price you put on
It's
it.
a blessing.
Yeah.
It's a blessing. But I want to go back now to miscarriages. What are some of the factors? What are some of the reasons that a woman would have a miscarriage?
You know, women try to find things to blame themselves when a miscarriage occurs. They
You do feel as though your body has failed you.
No, don't think of it as a failure. Think of it as it's something that can occur. Your body has a way of policing itself, policing the pregnancy. And if it recognizes that something is wrong with the development of the fertilized egg and it decides that it's going to shed, it's shed. People try to say, oh, I was wearing high heel shoes, or I bent over, or I lift something heavy, or I wasn't eating properly, or I wasn't taking enough rest. I mean, there's no evidence to support any of these things cause a miscarriage. But when they get pregnant the next time, psychologically, if they don't abstain from these things, they think the same thing is going to happen again. And they come and ask me. And I said, the evidence doesn't support it. But if you think that you can abstain from these things and still function, and it will give you that peace of mind that, you know, you're not stressed out, that you had to wear heels or had to do something, and you want a letter to say you want an exemption from that, we give it. Sometimes just the thought that you may have contributed to it is a stress by itself. Mm-hmm. And we try to reassure our women that, you know, no matter what they do, there are people out there who get pregnant who don't even know that they're pregnant. And they continue to do many different things, abuse drugs and all those sort of things, and it doesn't cause miscarriage. I'm not going to tell you to do those things, but I can just say do everything in moderation, be responsible, and live a healthy life.
But Dr. Chatrani, still a lot more to discuss. Hopefully it would not be so difficult in the second half. Stay with us. You're watching One on One.
As Barbadians prepare for the Atlantic hurricane season, here is some information about shelters. Shelters are listed in two categories. A Category 1 shelter may be used during a hurricane or other hazard event, while Category 2 shelters may be used if they are still in a reasonable condition after a hazard event or disaster. Persons are advised to make their way to shelters well in advance of a storm's arrival.
Welcome back as we continue our discussion with consultant obstetrician, gynecologist, and gynae oncologist, Dr. Vikash Chatrani. Dr. Chatrani, in the first half, we covered quite a bit. Our last point was on pregnancy, miscarriages specifically. And I know there is I don't want to say a technique or a procedure that obstetricians conduct, where if a woman's womb is not strong enough to carry a pregnancy, you put in a stitch.
Okay, so that's a specific condition. What happens in some women is that their cervix or their neck of their womb, that's responsible for keeping the pregnancy in for 9 months. And that same cervix is what opens up to 10 centimeters to allow the baby to transition from the womb into the birth canal. Sometimes the musculature of the cervix can be very weak. And you see this in patients who've had multiple miscarriages, and what we call not just regular first trimester miscarriages, but these occur in the second trimester. So they get as far as 4 months, 5 months, and the neck of the womb opens up prematurely. In those circumstances, we can actually put in a stitch, what we call a cerclage. And it's a stitch suture that goes around the neck of the womb and tie it securely, put in a knot and a couple of knots. And this keeps the pregnancy in the uterus until they get to term. And then you remove that stitch and then they're allowed to labor normally. So that was a technique that was employed when we realized that there may be inefficiencies or weaknesses in the musculature around the cervix.
There's also the condition placenta previa, where the placenta is low-lying.
Okay, so first, to explain, in pregnancy, you have the baby and you have the placenta, or what some people call the afterbirth. The placenta is the interface between the mom in the uterus and the baby. So the cord actually comes from the placenta, goes to the baby, and the placenta attaches onto the uterus. Now, normally, if the placenta attaches, say at the top, it doesn't interfere when the cervix starts to dilate and baby goes into the birth canal. But abnormally, sometimes the placenta can actually implant close to the neck of the womb or over the neck of the womb, so that if you start to dilate, you would actually start to bleed from the placenta before you can actually deliver a live baby. So in scenarios where we detect the placenta to be low on ultrasound early in the pregnancy, we kind of monitor it to see if it moves enough out of the way that we can allow this woman to deliver normally and through the vagina. Sometimes it's too low, and despite waiting, it doesn't move. So what happens is that we don't allow these women to deliver vaginally. The reason for that is because when they start to dilate, they will start to bleed from the placenta, and that will have implications on the baby as well as the mother in terms of volume loss and potential adverse outcome.
Cesarean sections, how common are they?
We have a C-section rate about 33% in Barbados. That's about probably the average you would see. You would have places where it is more, like in Brazil it's over 50%. North America is just above us too as well. And it is being, cesarean section is an operative delivery. We do it in the past if there was a maternal indication or a fetal indication, meaning either there was something that was adverse to the mother if she were to go into labor, or a fetal indication, meaning it was timely to deliver the baby as quickly as possible versus waiting for the whole labor. But we've been having a lot of women now requesting cesarean section, what we call as per maternal request.
I wanted to ask because we see in North America women do request, but it is, I don't want to say a risky surgery, but you're peeling back 7 layers of...
Well, I didn't even know the amount of layers. Thanks for letting me know that, Lisa. I mean, we're not peeling back anything. What you're doing is basically dividing the tissue. So you're dividing the skin, the subcutaneous tissue, separating the muscles, going down to the level of the uterus, and what you're doing is making an incision on the uterus to deliver baby through the abdominal cavity and out.
Is it advisable though? I mean, if your body's strong enough to go through labor, you don't have any issues, baby doesn't have any issues, why would you want a C-section?
So you're right. The safest form of delivery for both mom and baby would be a natural delivery. But you have scenarios that occur like the placenta previa, or if you have a very large baby where the risk of passing through the birth canal has risks to the mother in terms of trauma and damage to her supporting structures, or risk to the baby on its way out if its shoulders get stuck, where a cesarean section is beneficial. And I think as obstetricians, we have seen improvements in our cesarean techniques and reducing complications like infections and stuff like that. So it is quite a safe procedure to do in this day and age.
But are some women requesting these C-sections? And you know where I'm going
Yes,
with
I know
this
where you're asking
because
me.
of vaginal stretching. They're concerned that it's not going to be, for lack of a better word, as tight as it was before.
Yeah, so women want to save the vagina by avoiding a vaginal birth, and they opt sometimes for cesarean section. And you as the obstetrician have to then counsel the women of the benefits and the risks. Having one C-section increases your risk for a subsequent C-section. Having one C-section increases your risk of placenta previa and other issues as you go on. Now, women obviously like a C-section because it's planned, it's timed. They get to choose when, they can show up for it. They have their baby, they know their baby's coming on this day, and they can kind of predict how the day is going to unfold versus going into labor, not knowing when it's going to happen, how long it's going to be, and how painful the experience is going to be. So I understand where they like control, but sometimes you have to trust your body too as well. I mean, body has been made to deliver babies naturally for the longest while. And if you trust your body, Obviously, have it under medical guidance where we can pick up things early. We can monitor the baby, monitor the progress, and only opt for a cesarean if it's indicated.
Yeah, because I've never heard anybody say that they enjoyed a C-section.
Really?
Yeah, it's a recovery period.
I've had patients who've undergone C-sections that are walking the next day, going home the next day, and compared to having the discomfort of dealing with stitches in their vagina or tears, thought of the recovery as a better experience than a vaginal delivery.
What is the most difficult labor and delivery you have ever supervised?
That's a very hard question to answer, because what you interpret me as interpreting as difficult is different for a patient. Now, obviously, a patient does not want to be laboring for hours. Their bodies get tired, they get exhausted. Mentally, it becomes exhausting. Physically, it becomes exhausting. I think one scenario that really hits home in terms of being difficult was where you and the patient could not, it wasn't even the patient, it's me and the partner of the patient. There was a compromise in the baby's heart rate in terms of the fetal heart was dropping, and this was an indication. She was in labor for a good 12 hours. Things were not progressing. There was challenges with the fetal heart, and we wanted to abort labor and do a cesarean section. And the partner convinced her no. And I've had colleagues who've been in a scenario like that where, you know, as an obstetrician, you know that the safest route of delivery at that time was to get the baby out as quickly as possible, and the partner says no. And then convinces the mother to say no. And you kind of see in front of you, you know, something that is not progressing. One, a baby's that could be potentially affected by changes in their heart rate where it can cause brain damage. And you want to avert that by promptly delivering them. And after the fact, I remember they coming back to me and telling me, you know, they misunderstood the circumstances. He just didn't want to see her in pain. But that was probably one of the most difficult times, because, you know, you felt helpless where you couldn't insist on something because it has to be a decision between the provider and the provider and the patient, but you had some obstacle in effecting and delivering the care that you thought was standard of care.
Since you mentioned C-sections again, we always hear that you should not have more than 3. Is that true?
That's not true either. So we call those higher order cesarean sections. Obviously, the risk increases each time you've had.
You're opening the same area.
Yeah. So when you say opening the same area, yes, you're going through the same tissue, but effectively the area is not open. So you're going through scar tissue.
Yes.
And every time you go through scar tissue, there's always a risk of more scar tissue there. But once you're a meticulous surgeon and you appreciate that you may encounter scars and adhesions, and you're accounting for that, there are ways to come around it.
So we spoke about pregnancy, fertility issues, labor, delivery. Let's look at the postpartum period.
That's one of the most challenging times.
It is.
And I always tell my patients, whenever they come pregnant to me, they say, oh, the rough time they're having in pregnancy. I always tell them, this is the easy part. This is the part that happens by itself. It's the part after. I often tell them in the 3rd trimester when they complain they're not getting enough sleep, I say, this is good sleep that you're getting. Because when that baby comes out, then you're going to see the lack of sleep. And most of them admit that you were right, you know. Pregnancy, I know it's an uncomfortable time, especially as the baby grows. It puts demands on your skeletal system. Your back feels it. Your posture feels it. Your mind feels it, because you feel like you have this new onset brain fog. You're not thinking or remembering things. You're tired all the time. Your feet are swelling. You just feel double the size that you're normally at, and you're moving slow. But
Those sound like all symptoms I have at the moment.
It's a lot. It's a lot to manage. It's a lot to manage your own self in that circumstance where you're not getting enough sleep, but then to manage a baby, and some people become overwhelmed. It's a lot of emotions that come in. I often ask a patient when they come back for their postnatal visit, how many times you cried? And if somebody tells me never, I would be quite surprised, because it is overwhelming. And that's where the partner's support, the family's support plays an important role. And that's why I usually advise my patients, you know, instead of reading, yes, read about the pregnancy, read about labor and delivery, but you have to remember labor and delivery is just a short time. Look at how to manage a baby after.
Life changes completely.
Yeah.
Having said that, because your body is also healing during that period, just going through a lot of hormonal changes as well, is 3 months enough time?
that sounds like a political question.
I'm not
So-
asking you to speak on policy. I'm
Okay,
asking you as
so-
a medical
So
professional.
usually your body returns to normal 6 weeks postpartum. In terms of all the physiological changes that occur in pregnancy, revert to normal 6 weeks after you deliver. And I see you smiling at me, and you want me to say otherwise. If you
I
could,
do not.
If you can spend as much time with your newborn without having to go back to work, that would be the ideal. If you can have your partner, give them paternity leave, and they come home,
Yes,
and, they,
we're
and they-
moving in that
and they
direction.
give you that assistance that you need. And you may think, but what the partner can do, they can give you a break. You can express breast milk. You can go and get a 5-hour, 6-hour nap, which is a lot for somebody who is just delivered. Often women don't sleep more than 3 or 4 hours at a time. And
Definitely.
you know how important sleep is for mental health. So anything that supports you getting assistance, whether it mean getting leave for your parents, grandparents, partner, I'm for.
So Dr. Chatrani is saying 6 weeks.
No, you asked me all the changes that occur in your body. And I said those changes revert back to normal within 6 weeks. But if you're asking me now if 12 weeks is enough to look after a newborn, no. I feel up to a year. These newborns, babies are demanding.
Yes, they are.
Yeah, and you may,
That's what I wanted to hear you say.
yeah, I know you want me to say that, and I'm going to tell you that easily. I have a 3-year-old and a 6-year-old. A 3-year-old is demanding.
Yeah,
That's why I
that's
said
very
the more time you could get, the better.
That's all I wanted you to say.
I'm being difficult since you used that word to describe me earlier.
Moving on, switching now to gynae oncology and looking at gynecological cancers. Cervical cancer, which is the most popular that we've heard over the years. Let's look at cervical cancer.
You said the most popular, but you know our cervical cancer rates are on the decline.
You're telling me.
I'm telling you, it's improvements in healthcare. Since the 1970s, women have accepted pap smear as part of their DNA. They go and get screened. A pap smear is not done to pick up cervical cancer, you know. A pap smear is done in an asymptomatic woman. She goes to her doctor just for a routine check to pick up abnormalities that can lead to cancer years down the line. And because women have embraced that, we have seen a constant decline in cervical cancer incidence over the years.
What are you seeing in your practice in terms of age groups and diagnosis?
Right, so specifically for cervical
Yes.
cancer, it's usually more common in the 30s and the 60s. So up to today, I operated on a lady in her 30s with cervical cancer. And that she had no screening. She never did a pap smear. You know, she presented with symptoms, bleeding after intercourse, what we call postcoital bleeding or intermenstrual bleeding, bleeding between the periods. She went to her doctor. They saw, oh, maybe the cervix looks a little bit inflamed. Did a pap smear or did a biopsy. They came back showing cancer.
What stage was she at?
She's at stage 1, fortunately for her, and that's why she was able to undergo surgical management. But a lot of them ignore the signs and the symptoms, and they present later. And that's one of the most preventable cancers there is. You can actually eradicate cervical cancer, you know.
Because it's a slow-moving cancer.
One, not only that, but two, there's now a vaccine for cervical cancer. Since 2008, what they have been able to prove is that a virus called HPV, or the human papilloma virus, is responsible for causation of most cervical cancers. I would say over 99%. So if you can get a vaccine, which has gone through rigorous testing, decades of testing, that can prevent persistent HPV infection, you can prevent cervical cancer. So how this came about is that with the introduction of the pap smear, we saw a decline in cervical cancer rates. What happened is that that decline now has started to plateau. And the new arm in the fight against cervical cancer is the vaccine. If you can now prevent persistent HPV infection, you can take that percentage down to 0 and eradicate cervical cancer.
There is some confusion. I even have this discussion amongst my girlfriends. Is it a case where you go once every year, once every 2 years? If you've had 3 consecutive clear pap smears, do you miss a year? There's confusion there.
Okay, so that's a very good question. The key is to have a normal pap smear. Now, how often should you do a pap smear test? I tell my patients every year.
Yes.
Okay? Most insurance cover pap smears on a yearly basis, and they come to me and tell me, you know, I don't want to do it every year. They've read in England that you can do it every 2 years or every 3
Yes.
years. Well, you have to understand where you're reading the guidelines from. In England, it's the National Health Service, the NHS. And what they've done through health economic research has shown that you can, if you've had 3 normal pap smears consecutively, that you can increase the interval of pap testing to 2, maybe even 3 years. And you may still, in that 3-year time, pick up an abnormality, but not at the cervical cancer diagnosis. And that's what pap smears are for, to pick up abnormalities that can lead to cancer. So if the abnormality is at type 1, type 2, or type 3, if you wait 3 years, you may pick up the abnormality at a type 2. I don't want to say stage, but at type 2 degree of abnormality before you get the cervical cancer, undergo treatment and get you back to normal. So when they looked at the health economics of it, it actually costed them more to do PAPs on women every year consecutively, how much ever million population they were serving. And they realized that if they increased the interval to every 2 or 3 years, they saved money.
But do you understand why a woman would want to come to you every 2 or 3 years? These hurt a lot.
So you make it look, come give it to me.
No, they hurt.
They do hurt, but you have to make it, these are soft thistles, okay?
They don't feel soft.
Touch them.
No, not
So
there.
you have to understand, it's the actual pap smear, but the whole process of going through it. If you have a woman in a private, secure environment, they feel covered. You all have accepted it. I mean, and kudos to you. Men avoid the umpire. I call him the umpire because
Yeah.
it's just a finger to examine your prostate. But if you think about it, when you think of a pap smear, you think of going into
It's
a room.
invasive.
You're going into a room naked, first of all. You're meeting somebody that you never met before. 1, 2. They have this cold speculum, touches your skin, and you feel that instant cold down there. It's being advanced and inserted and expanded. So
You just explained why we don't like doing that.
hold on, because you've experienced it that way. But if you go to somebody that you trust, you have a secure, private, clean environment, you're given a gown, you're given a sheet, something to cover your lap, you feel respected, you maintain some level of modesty, you don't use the metal ones, you use plastic, softer, right? Warm jelly, inserted with, once you relax, you go through a breathing technique. Cervix is identified and you're not using the hard thistle brush that you have something as soft as this that we can do.
Let me
quick.
see how soft this is. You might not feel that soft there though.
Yeah. So it depends on what you use and how you do it. And to give you all credit, you all have accepted this, you know.
Yeah.
And you were
Women love
asking me,
doctors.
are you been begging now? Why can't we do it every year? You know, and you nodded when I said some people.
No, I go
recommend
every year. I go
But you
every
go
year.
every year,
I go
even
every
though
year.
it's.
I
you
go
know,
through that every year.
Yeah. Well,
That I don't know. if
prevention
that's
is better
soft,
than
though.
cure.
Of course it is.
You know, doing your screening test, and not only your pap smear is a good screening test, your mammogram,
Yes.
above 40, 45, your colonoscopy, your blood pressure checks, your weight checks, all of those are important things.
So on your pap smears, I come to you. Unfortunately, I do have an abnormal pap smear. What's the next course of action?
So usually an abnormal pap smear, most people think pap smears are picking up infections and stuff like that. That's an extra bonus of a pap smear. If you tell me your pap smear is abnormal, mean they're abnormal cells. And those cells need further evaluation. So to just understand what we do with a pap smear, if this is your cervix and you take that thistle brush and you take a puff of cells, I'm using the words that sound a little bit less traumatic,
Thank
and
you.
you send those to the lab and they examine them under the microscope and they say, well, they look like these cells are a little bit abnormal. Then what we need to do is something called colposcopy.
Yeah.
Big word. Colpo means cervix in Latin. Oscopy means to look at the cervix. So what you're basically doing is that you're bringing the microscope in front of the cervix and you're looking at the cervix directly. So the patient comes in, gets in the same position that they were getting for a pap smear, but now you bring a microscope in front of them and you magnify the cervix. You put these different solutions on the cervix to try to highlight those abnormal cells and the abnormal tissue. You're going to take samples from those areas that highlight. And what you basically want to do is to confirm the abnormality so that you can give the best treatment. Best treatment may be freezing and getting rid of the cells, or actually lasering or cutting those cells out to remove them completely.
There's also something called loop cone.
That's correct, right? One of these handouts talk about it, a loop cone. So basically what a loop cone is using a small metal loop that has electrical current through it. And what that does, it acts like a cutting device and it can actually cut out and scoop out the abnormal cells.
What
And
is
it's
your
done-
preferred choice?
It all depends on the type of abnormality. So if it's a mild abnormality, you can freeze those cells. You melt them. With a loop cone, what that allows you to do is the tissue that you remove, You can send that for further testing in the lab to see that you've gotten all of it, that all the edges are clear, so that the patient, when they leave, they know that everything has been removed.
And what's the youngest patient you've diagnosed with cervical cancer?
Fortunately, in their 20s. It's not common, but you're always going to have outliers. So if you ask me what's my youngest, it's not to really raise alarm, but to say that it can occur.
It has happened.
Yeah.
Ovarian cancer.
Unfortunately, ovarian cancer, there are no good screening tests like the pap smear. So you have to rely on symptoms. Patients, and these symptoms may be mild: abdominal bloating, discomfort in their lower abdomen, changes in weight, little distension, changing in bowel habits. What they should do is seek medical advice. Okay. What we can do as physicians is we can scan the ovary with an ultrasound and look at the size, look for the presence of cysts, and look for biochemical markers that may suggest that this is something abnormal. But what I would really suggest women do is go for their yearly checks, and report any changes in symptoms that they may have. Now, I'm not telling you that if you start peeing more often, your tummy feels bloated, or you had a bad bowel movement, that you automatically raise the
Or
alarm.
go on Google.
Or you go on Google,
Yeah.
raise the alarm. But if you pay attention to your body and something changes, and that change persists for more than 2 weeks, then that's a sign to go and get checked. I know women like to diagnose themselves all the time. They may get burning when they pass urine, frequent urination. They say, well, I have a UTI. And they go to their pharmacist, who's friendly enough to give them a prescription, and the symptoms go away. And they say, see, I was correct. But sometimes these symptoms persist, and they don't respond to conventional treatments that you may think is conventional for you. Those are the ones that you need to go for and get medical attention and get checked out. Because sometimes it may not be a UTI, it may be something more. So if the symptoms come on and they persist for more than 2 weeks, then they need full attention. Cases of cervical cancer declining, cases of ovarian cancer pretty constant. All cancers are on the rise. And you may ask why. It's actually because of improvements in healthcare. And you say, but how can improvements in healthcare lead to more cancer cases? Yes, it could be because of diagnostic and detection tools, but it's also because of women living longer. If you were going to die of diabetes 30 years ago in your 50s and you're living to 70, 80, or you're no longer dying of hypertension or stroke, your lifetime risk of developing cancer increases. So, yes, we have good diagnostic modalities and we're not picking up cervical cancer, but we're picking up abnormalities before cervical cancer so we can treat it. So our cervical cancer rates are going down. Ovarian cancer, pretty constant. You know what's going up? Womb cancer or endometrial cancer. That's on the rise. And the Ministry of Health called me the other day just to see, is there something that we can implement to help, screen for these cancers or reduce these cancers? And unfortunately, endometrial cancer is a lifestyle cancer in most cases. And when I say lifestyle, referring basically to the increase in weight that our women are experiencing. And with the increase in weight, remember we mentioned earlier in the first session that fat cells produce estrogen. The more estrogen in your body, the more it stimulates the growth of the lining of the uterus called the endometrium, and the increased chance of that undergoing cancerous change. So when you want to look at it from a policy perspective, what can we do to introduce in the country to help reduce endometrial cancer? It's really lifestyle changes. It's basically practicing healthy lifestyle habits, not overeating, maintaining a healthy weight, exercising, but also knowing the most common symptom that occurs in patients with endometrial cancer, which is postmenopausal bleeding or bleeding after the menopause. When we discuss menopause, we appreciate that menopause is the absence of periods for a year. Periods don't come back. They're not like governments, I always say. So if you have gone through menopause, 1 year with no bleeding, and you started to bleed again, that's abnormal. You need to present to your medical practitioner for further investigation. Or it may not be as classic as that in terms of postmenopausal bleeding, but you may actually have irregular bleeding around the time of menopause. You may miss 3 months, 4 months, and then it bleed. Or you may be all 55, 56, 57, still getting this irregular bleeding. That's not normal. If you're supposed to transition into menopause between 50 and 53, and you continue to bleeding, you say, well, I never went a whole year without bleeding, and you think that these are your periods still coming, that's a flag that should be raised in your head. Usually women don't go beyond that with irregular periods.
I know I asked about cervical cancer in terms of your youngest diagnosis, and you said in the 20s, uterine and ovarian, your youngest patient.
Uterine, I had somebody in their young 30s that we diagnosed with uterine cancer quite recently. That's young. And in her case, it was a chance finding in terms of she had a problem with an ovarian cyst. But in her case, it was rare to have, she had no bleeding abnormalities. Yes, she was overweight. That is a risk factor, but it's quite unfortunate to be just that, having that only risk factor, which leads you to believe that there may be a genetic predisposition to be in your young 30s and then diagnosed with uterine cancer. Up to today, we operated on a 13-year-old.
A what?
13-year-old, 1-3, with an ovarian tumor. And her history was not that long. Mommy noticed that her tummy was getting a little distended over the Easter holidays. And when we did her imaging test, we found that she had an enlarged ovary. So it's an ovarian tumor. The diagnosis hasn't been confirmed as yet as to what is the cause of the tumor. But I've had somebody in my teens already before diagnosed with ovarian cancer.
Outside of cervical cancer, then, when we look at these gynecological cancers where the screening is not as easy to do, what stage are you picking up these cancers?
So endometrial cancer is actually one of the better cancers to get. If you were to choose one cancer, I would tell you choose endometrium. Why? Because the womb is like a tomb. So it has a muscular wall. It's the lining of the womb that undergoes cancerous change. So usually you get symptoms. You start to bleed before the cancer invades the walls or the muscles and spreads to the rest of the body. So if you had to choose something, one of the cancers to get, I would say endometrium, because you are going to get an irregular bleeding or you're going to get postmenopausal bleeding. So your body tells you something is wrong. So that if you then present early and you get treatment where we take out the womb in its entirety with the cancer, you achieve a better cure rate. So to me, that's the ideal scenario. Unfortunately, with the ovaries are hanging on the side of the uterus. So if they undergo cancerous change, yes, they may form cysts early, but these cysts then release cells. And once they get released, you're actually going from a stage 1 to stage 3. So it may present later. Cervical cancer, that is something that should be something of the past. Because if you do your screening tests and you get your pap smears on a regular basis, you get vaccinated, we should actually see the elimination of cervical cancer if we all do what we're supposed to do. We do pap tests on women, we vaccinate young girls, but we also vaccinating boys. So if you can get herd immunity and you reduce HPV transmission, you can effectively nearly eliminate cervical cancer.
Do you think that women understand their bodies enough?
I think so. Most women do. We do find the newer generation probably that is not passed down, but in the olden days, you know, your granny used to tell you, your mommy used to tell you, and you kind of have that knowledge. Probably with the younger generation, I don't see it. It's a new thing. The younger generation is just completely different. They call them the cancel culture, and they have different names for them, but you have to spend more time with them, and usually they're accompanied by their parents or somebody a little bit older, and you can explain, but sometimes you feel like you're still not getting through. So when you try to explain to them, you realize that there are deficits there in knowledge, but you try to enlighten them to the best of your ability.
All right, Doc, well, the floor is yours in terms of advice to women, not waiting until you actually have symptoms, but coming before.
So have healthy, health-seeking behavior, meaning do what you know in your mind is right. Eat healthy, and eat healthy does not mean only fruits and vegetables. You can eat proportionate meals, a mixture of meals with meats, vegetables, but don't overeat. Live a healthy lifestyle. And when I say that, don't smoke, have safe sexual practices, exercise regularly. A lot of people tell me, oh, they walk up and down for work and this and that, that's enough. That's not exercise, that's your normal daily activity. But if you can maintain a healthy weight, eat a healthy weight, live healthy, then if anything happens, you're not to blame. Because if you do everything healthy and you do everything in moderation, you should have a good outcome when it comes to health.
Dr. Chatrani, I appreciate you taking the time to speak with us this evening. I know you had a full day of surgery, so really appreciate your time and advice.
Well, thank you. And it's not too late for you to try for that that child.
You never know.
Yeah.
You never know. One more can't hurt. Or maybe,
I know the NS will be happy.
if I could get more than 3 months, maybe we will discuss it. Thank you very much.
problem.
That was consultant, obstetrician, gynecologist, and gyne-oncologist, Dr. Vikash Chatrani. I'm Lisa Lord. You are watching One on One. Do have yourself a wonderful evening.